Hello, my dear. I'm Dr. Alaa Mosbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. The topic of my lecture today about bleeding with pregnancy. So, what we want to discuss today, the causes of bleeding during pregnancy and whether early pregnancy bleeding or antepartum hemorrhage. So, what are the causes of bleeding during pregnancy? We can divide them into two big groups. Early pregnancy bleeding before 20 weeks gestational age, especially or more commonly during first trimester, and the other big group is antepartum hemorrhage, which is bleeding after 20 weeks gestational age. So, what are the causes of early pregnancy bleeding? Miscarriage, ectopic pregnancy, molar pregnancy, and other gynecologic lesions like polyp, like cervical ectopi, like cervical carcinoma. Okay? So what about antepartum hemorrhage? Causes either placenta previa or appropriate placentae or vasa previa or gynecologic lesions like cervical ectopi, cervical carcinoma, cervical polyp, and so on. Okay? This is the most common causes. Of course, antepartum hemorrhage include other causes like silent rupture, uterine rupture, like excessive show, like different other causes. Okay, so but we are going to discuss today in antepartum hemorrhage the placenta previa, the appropriate placenta, and the vasa previa. Okay, and we are going to discuss in early pregnancy bleeding the miscarriage, the ectopic pregnancy, the molar pregnancy. Okay. So let us start with bleeding during early pregnancy, which is defined as vaginal bleeding occurring 20 to 30% of confirmed pregnancies during the first 20 weeks of gestation, mostly during first trimester, as I said before. The causes may be miscarriage, ectopic pregnancy, molar pregnancy, or local gynecologic causes like cervical cancer or polyp. So what about the miscarriage? Let us start with the miscarriage. What is the definition of miscarriage or abortion? First, miscarriage or abortion used differently in different countries. Some define miscarriage as term used to denote spontaneous loss of wanted pregnancy, while abortion is a term usually used to denote medically or surgically augmented voluntary termination of pregnancy. Okay, while in some countries they are using miscarriage and abortion as the same meaning. Okay, so there is a little difference between countries about this point. So what's the definition of miscarriage? This is a term used to represent vaginal bleeding with or without abdominal cramps in early stages of pregnancy, less than 20 weeks of pregnancy, okay, which may lead to expulsion of the fetus before being capable of extrauterine life. So there is pregnancy, there is bleeding, there is abdominal cramps, uterine colic, and there may be expulsion of part of the product of conception or all the product of conception, or just bleeding and the baby is still inside. Okay, so this is what is the meaning of miscarriage. Okay, miscarriage may be early or late. If it is before 12 weeks gestation age, it is early. If it is after 12 weeks till less than 20 weeks gestation age, it is called the late miscarriage. So what is the definition of recurrent pregnancy loss? Recurrent pregnancy loss in the United States, they consider 2 or more consecutive failed clinical pregnancy documented by ultrasound or histopathology is considered recurrent pregnancy loss. While in the Kingdom, they consider 3 or more consecutive early pregnancy loss. So the difference here in the number of the pregnancy loss. In the United States, it is 2 or more. In the United Kingdom, it is 3 or more. What is the epidemiology? Up to 10% of clinically recognized pregnancy end in miscarriage. But actually, the truth about the incidence of miscarriage is higher than that, maybe reaching 26%. But it is not diagnosed clinically. Okay? So, we are going to say this is the incidence of the epidemiology of clinically recognized pregnancy. It is 10%, up to 10%. Okay? 80% of early pregnancy loss occur in the first trimester. What are the risk factors of miscarriage? Increasing age above 35 years. This is the most significant risk factor. It is associated with fetal chromosomal abnormalities more than younger age. Previous miscarriage. This is another risk factor. Medical condition in the woman, either obesity, diabetes mellitus, thyroid dysfunction, or metabolic disorder, or cardiovascular disease, or infections like bacterial, viral infection, or inherited thrombophilia. Also, pregnancy on top of intrauterine device is another risk factor. Medications that may be taken by the woman while she is pregnant may cause miscarriage. Environmental factors like exposure to toxins and other environmental factors. Preconception paternal medical condition. This is related to the husband. Either abnormal sperm, as in old age, or drug addiction, or metabolic diseases. So what are the etiologies of miscarriage? The commonest, and you should remember, especially in the early pregnancy loss, in the first trimester, is chromosomal abnormalities constitute up to 70% of pregnancy loss. Okay? Okay, so chromosomal abnormalities. Maternal anatomic anomalies. Congenital uterine anomalies like unicorn uterus, septate uterus, uterine myomas, polyps, adhesions. Okay? So intrauterine adhesion like Asherman syndrome can cause miscarriage also. Trauma, significant trauma can cause pregnancy like motor car accident and whatever. Infection like torch, toxoplasma, rubella, cytomegalovirus, herpes simplex, and so on. Causes of second trimester pregnancy loss, including infection like chorioamnionitis and maternal viral infection, chronic stressors. What's the chronic stressors? Including financial stress, chronic food or housing insecurity, uterine malformation and cervical insufficiency. Cervical incompetence is one of the common causes of second trimester miscarriage. Fetal malformation or syndrome, like anencephaly, trisomy, renal agenesis, or hydrops, thrombophilia, placental rupture, premature preterm rupture of membrane, and environmental factors like exposure to radiation. So, you remember when we said recurrent pregnancy loss, 2 or more or 3 or more pregnancy loss? Okay, what are the causes of this recurrent pregnancy loss? Genetic, please remember genetic first. Aneuploidy is one of the most common causes. Anatomic, congenital Mullerian tract anomalies, like septate uterus, unicorn uterus, cervical incompetence, and so on. Uterine hypoplasia. Endocrine disease, diabetes, and thyroid dysfunction. Antiphospholipid antibody syndrome constitute 8 to 42%. It's very important. Immunological, inherited thrombophilias, environmental factor like alcohol drinking or cigarette smoking or cocaine use. So what are the types of miscarriage? Please look to the picture. We have threatened miscarriage, inevitable miscarriage, missed miscarriage, complete and the incomplete miscarriage, and the septic one. Okay? What is the threatened miscarriage? Threatened miscarriage, there is viable fetus intrauterine, there is closed internal os, and there is bleeding and mild pain. Okay? Okay. But inevitable one, there is severe bleeding, there is dilated internal os, and the fetus usually not viable as diagnosed by ultrasound. Okay? What is the complete miscarriage? As in this picture, the product of conception completely expelled outside the uterine cavity. So when you do ultrasound, you'll find the uterus is empty with no remaining product of conception. What is the missed miscarriage? The missed miscarriage, there is intrauterine embryo, but non-viable one. And the internal os is closed, and there may be no bleeding or some brownish discharge, okay, or brown juice discharge. What about incomplete miscarriage? The product of conception partially expelled outside the uterine cavity. There is remaining product of conception is still inside the uterine cavity, and the part of the product of conception expelled, and of course the cervix is open, the internal os is open, and there is bleeding. What about cervical miscarriage? Cervical miscarriage means the product of conception expelled inside the cervical canal. Expelled inside the cervical canal, as you see. The internal os is open, and the product of conception expelled from uterine cavity to the cervical canal. And also diagnosed with TVS easily. Okay, how to diagnose miscarriage? Most commonly, the patient will present with missed period or abnormal menstrual cycle. There is symptoms denoting early pregnancy like morning sickness, craving to certain type of food, fatigability, sleepiness, and so on. This is the early pregnancy symptoms. And there is positive pregnancy test. There is abdominal cramp. There is vaginal bleeding or brownish discharge or passage of fetal tissue according to the type of miscarriage. There may be gush of water per vagina, as in case of rupture membrane, especially in second trimester. Okay, what are the signs? Of course, it depends on the type of miscarriage. As I said, there is many types. Generally, the uterus is enlarged, soft, okay? The cervix may be dilated or not, the internal os, I mean. Fetal part or amniotic sac may be felt passing out of from the cervix, especially in incomplete abortion or inevitable abortion. Then you may find the product of conception coming from the internal os or inside the vagina. The investigation needed, of course, two important investigations: transvaginal sonography and serum beta HCG, CBC, blood group, and Rh factor. Of course, Rh factor, because Rh negative woman is a very special case. Okay. Ultrasound. This is the gold standard to know the viability of the baby inside, okay, and the gestational age. And if you did beta HCG, and it was a quantitative one, of course, and the level was 1,500 up to 2,000 milli international unit per milliliter, okay, so I should see intrauterine sac by transvaginal ultrasound, okay. This is what's called the discrimination zone. Okay, ultrasound with quantitative human chorionic gonadotropin hormone level can help determine viability. We know that HCG doubled within 48 hours during the first 10 weeks of gestational age. Doubled, if you did it today, then repeat it after 48 hours, you will find it double the beta HCG level. Okay? This is denoting the baby is viable, okay, and doing well. Cardiac activity should be identifiable at crown rump length of 5 millimeter or greater. Sometimes we may find a sign by ultrasound called anembryonic gestation. What is the anembryonic gestation? Anembryonic gestation means there is gestational sac large more than 25 millimeter with no embryo or yolk sac. Okay, so some call it blighted ova, anembryonic gestation, and so on. What is the differential diagnosis? You remember when we said other causes of bleeding in early pregnancy, like ectopic, like Muller pregnancy, like viable pregnancy with implantation bleeding, like viable pregnancy with complication, like pregnancy with gynecologic pathology, like cervical polyp carcinoma, and so on. What is the treatment? Generally, we have expectant management, medical management, and surgical management. Expectant management means waiting for natural release of pregnancy tissue. It is recommended as the first line option for women with incomplete miscarriage. It may be effective in 90% of cases in case of incomplete miscarriage, provided there is no evidence of excessive bleeding or intrauterine infection. Okay? So long as there is no excessive bleeding and no intrauterine infection and the case is incomplete abortion, spontaneous expulsion will happen for the remaining part of conception. Okay? So, watchful waiting is less effective in patient with an embryonic gestation or embryonic demise, as in case of miscarriage. Okay? So, it is less effective. But expectant management can be used only with incomplete miscarriage with 90% successful result. Okay, what about the medical management? Medical management like using misoprostol, which is synthetic prostaglandin E1 analog. Why we are using misoprostol? Causing softening in the cervix and the uterine contraction. What is the regimen? 800 microgram vaginally can be repeated after 24 and 48 hours if the first dose is unsuccessful. Okay? Okay. Besides the expected cramping and the vaginal bleeding, common adverse effects include nausea and diarrhea, and should counsel your patient about that. Another medical management is the mifepristone, which act as a competitive progesterone and the glucocorticoid receptor antagonist. Okay? This is another method for treatment, for the medical treatment, is to use mifepristone 200 milligram oral. Okay? Okay. Some prefer to use a combination of misoprostol and mifepristone with more successful result if we use the both of them. They are more effective than misoprostol alone. Okay? The most effective regimen for medical management is oral mifepristone 200 milligram. Then after 24 hours, give 800 microgram misoprostol vaginally. Okay? So start with oral mifepristone 200 milligram oral. Then after 24 hours, give the patient 800 microgram misoprostol vaginally. Okay, let us go to the surgical treatment, which is the surgical evacuation. As in this picture, either you're using dilatation and curettage with methyl curate, or which is more better, the manual vacuum aspiration with shorter duration, more safe, easier using manual vacuum aspiration as you see. Okay? Okay. The surgical evacuation is preferred in which women? Those presented with hemorrhage. There is no time for using medical treatment and so on. You should interfere with surgical evacuation by MVA or use ovum forceps and the metal curette and so on. So, in hemodynamic instability with severe bleeding, if there is signs of infection, because this condition require urgent treatment. Success rate for surgical evacuation nearly 99%. Prophylactic antibiotic may be needed before miscarriage, especially in low-income and middle-income countries to avoid the risk of infection. Okay. Then remember, if your patient is Rh negative and her husband Rh positive, you should give her anti-Rh. Okay? What is the dose of Rh immunoglobulin? 50 microgram, okay? If it is within up 50 to 150 microgram. If it is within the first 12 weeks. If it is more than 12 weeks gestation age, I should give the higher dose, which is 300 microgram, okay, to prevent alloimmunization. Of course, should be given within 72 hours. The earlier, the better. Within 72 hours from surgical evacuation. Follow-up, yes, you should do follow-up using ultrasound to be sure that the uterus is empty, beta HCG level at least 50% drop at 2 days after evacuation, or 87% at 7 days. Okay? What about contraception? If the patient wants to use contraception, you can advise her to use it immediately. Okay? And you should counsel her about the different methods of contraception. Let us go to the threatened miscarriage. Threatened miscarriage is a special type of miscarriage. Here, the baby is living, viable, the internal os is closed, the bleeding is mild, so I still have hope for continuation of pregnancy. Okay? So, it is defined as vaginal bleeding before 20 weeks gestation age in the setting of positive urine and or blood pregnancy test with closed cervical os without passage of product of conception and without evidence of fetal or embryonic device. Okay? So the baby is still living. Okay. The diagnosis of threatened abortion should be made in patient with bleeding and an ultrasound confirmed viable intrauterine pregnancy. Okay. What if there is intrauterine pregnancy but viability is uncertain? What you are going to do? Please do another ultrasound after 7 days to confirm viability. Okay? And at the same time, if you did quantitative beta HCG, you will find it increasing. If you did it today, then you repeat after 48 hours, you will find it increasing up to double the level. What is the prognosis of certain miscarriage? The rate of early pregnancy loss is approximately 11% after a live fetus has been detected on ultrasonography. But the risk of early pregnancy loss is increased when subchorionic hemorrhage, as in this picture, this is the sac, the intrauterine sac, and this is the subchorionic hemorrhage. If this sign is present, especially if it is large one, and associated with vaginal bleeding, the possibility of pregnancy loss is higher. What is the treatment of threatened miscarriage? Progesterone hormone administration, especially the micronized progesterone, 400 milligram twice daily, vaginally. You can give the patient analgesia for the abdominal cramps like acetaminophen. It is safe. Please don't give the patient non-steroidal anti-inflammatory drugs. So acetaminophen is safe. Okay. What is the treatment of threatened abortion also? You can give the patient folic acid, of course. You already started it from the start of the pregnancy, so you continue giving folic acid supplementation to prevent neurological tube defect. If the patient Rh negative, you should give her Rh immunoglobulin. As I said before, if the pregnancy less than 12 weeks, you can give the small dose of Rh immunoglobulin, which is 50 to 120 microgram. If the pregnancy is more than 12 weeks, you should give the larger dose, which is 300 microgram. What if the pregnancy less than 12 weeks and I can't find in the pharmacy the smaller dose, 50 up to 120? So I can give this this case the larger dose, which is the 300 microgram. No problem with that. Okay. Okay. You are going to ask the patient to avoid strenuous activities, marked activities. Okay. And to maintain pelvic rest, avoid sexual intercourse, inserting any foreign body inside the vagina, and so on, at least until cessation of vaginal bleeding. What about bed rest? Recently, it is not advised to ask the patient for complete bed rest because there is risk of deep venous thrombosis and thromboembolism, and is not going to improve the case of threatened abortion. So just the limitation for excess activities, the strenuous activities is limited, okay, or avoid, okay. Special case of miscarriage or abortion, which is septic abortion. What is this category? This is an infection superimposed on any type of abortion, most commonly incomplete abortion, as the remnants inside the uterus form an excellent culture medium for organisms. Okay? Septic abortion results from induced abortion done by untrained practitioners using non-sterile techniques. They are much more common where induced abortion is illegal. What are the organisms? The common organisms: streptococci, staphylococci, E. coli, Clostridium wilshire, and the tetani. The mode of infection may be exogenous, endogenous, or autogenous. How the organism reach the product of conception and the cause septic abortion. Exogenous from attendants, physician, or instruments. And the type of organism here mostly is Streptococcus hemolyticus. Or endogenous, there is ascending infection from organisms already present in the genital tract, like anaerobic streptococci. Or autogenous from a septic focus in the body through bloodstream. Okay? There is septic focus in the body. There is cholecystitis, there is appendicitis, there is another infection in other part of the body. Through bloodstream, the organism can reach the product of conception and the cause septic abortion. Okay. What is the clinical picture of septic abortion? Of course, history of recent trial to induce abortion. There is general symptoms and signs of infection like fever, sweats, chills, shortness of breath, palpitation. Okay. The localized signs of infection include, of course, offensive vaginal discharge, uterine tenderness. What is the complication of septic abortion? Septicemia and shock. This is very dangerous and life-threatening. And the renal failure, of course. Investigation needed, of course, ultrasound. I need to do also lab investigation like CBC. There is leukocytosis, iron R, and coagulation and the bleeding profile, because those patients liable for bleeding tendency and DIC, blood culture, kidney function test like serum creatinine. What is the treatment of septic abortion? Isolation of the patient in the hospital, give and rest, and they give the sedative to the patient, fresh blood transfusion, observation of the vital signs is very important, the pulse, blood pressure, temperature, respiratory rate, fluids, intravenous fluids, urine output, follow up. Patient nursed in semi-sitting position. Give the patient broad spectrum antibiotics against aerobic and anaerobic organisms, and also according to the blood culture and sensitivity test. Sometimes you may need cortisone injection to save life. Lastly, under umbrella of antibiotic, evacuation of intrauterine content is done using the most safe way, which is the manual vacuum aspiration under local anesthesia. There is expression called pregnancy of unknown location, BUL. Here in such case, there is a missed period, okay? There is a positive pregnancy test, but when you are going to do ultrasound, you can't find where is the site of pregnancy. Either intrauterine or extrauterine. You cannot define if there is intrauterine or extrauterine pregnancy. This case, we call it pregnancy of unknown location. What we are going to do, simply we are going to do serial quantitative beta HCG test, also follow up with ultrasonography until either there is evidence of intrauterine pregnancy or evidence of ectopic pregnancy. But the problem is, if we cannot find the location, still cannot find the location of pregnancy and the beta HCG is increasing, this is the most dangerous and the most important case. Here you may give the patient, you may reach to give the patient chemotherapy and do follow up with quantitative beta HCG until it is dropping and becomes negative. Of course, with doing this at the same time ultrasound, okay, especially the transvaginal ultrasound. Let us go to the next topic, which is important, ectopic pregnancy. As you see in the picture, the commonest is tubal ectopic pregnancy. Okay, what is the definition of ectopic pregnancy? Ectopic pregnancy occurs when developing embryo implant at the site other than the endometrium or the uterine cavity. Most commonly within the fallopian tube. It is one of the most common gynecologic emergencies. Okay, what is the incidence? Please look at the picture. Ectopic pregnancy constitutes 2% of all pregnancies. Okay, and in women using assisted reproductive technology, it is increasing to 5%. Okay. Okay. Ectopic pregnancy more common in fallopian tube constitute 95%. Okay, 70% of this 95 occur in ambulatory portion, the widest part. 12% in the isthmic portion, the middle portion, which is the narrow portion. 11% in the fimbrial. Okay. So what is the commonest? Is the ambulatory portion, 70%. Interstitial, the part of the tube passing through the cornea, is called interstitial. This is 2%. Ovarian pregnancy, ectopic pregnancy constitutes 3%, abdominal pregnancy 1%, cervical pregnancy less than 1%, cesarean scar pregnancy is now recorded to be up to 4% in the site of the scar of previous cesarean section. What are the risk factors for ectopic pregnancy? Women with period ectopic pregnancy have 10 times higher risk of recurrence. Second risk factor, congenital tubal dysfunction. Another risk factor, acquired tubal damage from PID, pelvic inflammatory disease, or previous tubal surgery. Also, in Fitz-Hugh-Curtis syndrome, which is a complication of chlamydial infection complicated by PID and the perihepatic adhesions called Fitz-Hugh-Curtis syndrome. Genital surgery, endometriosis, and dysmenorrhea associated also can be considered risk factor for ectopic. Smoking increases the risk of ectopic. Mental health disorders like depression and anxiety. Intrauterine contraceptive device is another risk factor. In vitro fertilization, another risk factor. What is the clinical presentation and the history taking? Of course, you should take a full history from the patient, including menstrual, obstetric, to determine gestational age and evaluate the risk factors in all women of reproductive age. The women usually present with short period of amenorrhea, but sometimes there is no amenorrhea. Okay, there is bleeding and no amenorrhea, but mostly there is short period of amenorrhea. Abdominal pain, vaginal bleeding, shoulder pain due to peritoneal irritation, gastrointestinal symptoms, syncope or fainting attacks. But you should know that ectopic pregnancy may be intact or ruptured or chronic disturbed one. Okay? In acute ruptured ectopic, the patient usually hemodynamically unstable and he needs immediate surgery. While in undisturbed one, the patient is stable and you can complete the procedure of investigation and your workup. And your initial workup include confirmation of pregnancy by serum beta HCG test and by doing transvaginal ultrasound. Then do physical examination, evaluate the vital signs, pulse, blood pressure, temperature, respiratory rate. They're expected to have increased pulse rate and hypotension. And there is anemia from blood loss. Abdominal examination, focus on the location of tenderness in one iliac region and the rigidity due to peritoneal irritation, shifting dullness due to peritoneal blood. There is internal hemorrhage. Cooling sign, which is a bluish discoloration around the umbilicus, denoting also internal hemorrhage. The uterus is enlarged, slightly enlarged, soft. Okay. Mobility of the cervix from side to side causes pain. So painful mobility of the cervix from side to side, this is called Dud's sign. And this is for differential diagnosis from BID also, because movement of the cervix in BID also associated with pain. Okay. Tenderness in the posterior fornix, what's called Johnson sign. Tender, ill-defined adnexal mass, vary in size in the affected site. What is the lab investigation? Serial quantitative serum beta HCG is important. In normal pregnancy, the beta HCG rises and becomes doubled within 48 hours in the first 10 weeks, then become eventual plateauing. Okay? So use the quantitative beta HCG level and transvaginal ultrasound. If beta HCG level about 1,500 up to 2,000 milli international unit per milliliter, I should see intrauterine pregnancy if it is normal intrauterine pregnancy. But if it is ectopic, I'm not going to see intrauterine sac. Okay? Although the level reach up to 2,000 milli international unit per milliliter, so you should suspect ectopic. Okay, as you see in this picture, different signs of ectopic by ultrasound, either heterogeneous echogenic adnexal mass, free fluid in Douglas pouch, tubal ring, fire like that, but by Doppler ultrasound, ring of fire, as you see by Doppler, vascularity around the ectopic pregnancy. Okay. Also, you may find the sac extrauterine with fetal pool which is pulsating, and this is diagnostic one, but not, this usually not seen except in little cases to see the ectopic pregnancy outside the uterine cavity, okay, and there is fetal pool and the pulsation. Of course, this is a diagnostic. If there is disturbed ectopic pregnancy, you will find internal hemorrhage or free fluid in the pelvis. If you did caldocentesis, means aspiration from the posterior fornix through the Douglas pouch to aspirate the fluid there. If it is blood, this is a positive, as in this picture. Laparoscopy, of course, is a diagnostic, as in this picture. This is left tubal ectopic pregnancy, as you see the swollen tube by ectopic pregnancy. And also laparoscopy can be used for management, diagnostic and therapeutic. We can do salpingectomy or salpingostomy and so on. What is the differential diagnosis of ectopic pregnancy? The pelvic inflammatory disease, tubovarian abscess, ovarian cyst rupture or torsion, hemorrhagic corpus luteum. Also bleeding in early pregnancy, as I said before, miscarriage, molar pregnancy, and so on. Other causes of bleeding during the pregnancy: urethral stool, appendicitis. What is the treatment of fallopian tube ectopic pregnancy? Either expectant medical and surgical management. Expectant management, allowing the pregnancy to take its natural course with close physician follow-up until there is clinical resolution of symptom and the negative urine pregnancy test or negative serum beta HCG. Which patient you can do the expectant management, because it is risky. Of course, you are afraid from complication of ectopic pregnancy and the rupture and the internal hemorrhage. So if you are going to use the expectant management, which is rarely done, it's rarely because it is expensive, needs this very close follow-up, and carry also the risk of complication. So if you are going to use it in a patient hemodynamically stable, the ectopic is undisturbed, the level of beta HCG, serum beta HCG is less than 1000 milli international unit per milliliter, and during follow-up it is decreasing. Okay, so you are going to do serial ultrasound and serial quantitative beta HCG until it is negative. Okay, what about the medical treatment? Medical treatment by using methotrexate, which is a folate antagonist. Okay, single dose of methotrexate 50 milligram per square meter. Then do serial beta HCG measurement on day 4 and 7 post treatment, then weekly until resolution. A reduction less than 15% in beta HCG level between days 4 and 7 post treatment may indicate that treatment is inadequate. So, if you found this level of drop of HCG less than 15%, the treatment is inadequate. Means what? I need another dose of methotrexate, 50 milligram per square meter intramuscular. Okay? Then do close observation and serial measurement of beta HCG until it becomes negative, as I said before. Don't forget to do test for liver function because it is hepatotoxic. Okay? Is there contraindication for using methotrexate? Yes, of course. If there is ectopic adnexal mass larger than 3.5 centimeter, if the beta HCG level is 5,000 or more milli international unit per milliliter. Okay? If there is pulsating fetal pool on transvaginal ultrasound, so don't use methotrexate in such a condition. Okay? Do follow up for the general condition of the patient, do CBC, liver and renal function for the hazards of methotrexate in the body system. If the patient taking folate supplement, should stop it during the treatment. Side effects of methotrexate, including diarrhea, stomatitis, conjunctivitis, nausea, hepatic dysfunction, anaphylaxis, pulmonary damage, myelosuppression. So, in patients with liver or renal disease, I shouldn't give methotrexate syrup. Okay? Surgical treatment, which is laparoscopy. Laparoscopy is considered gold standard, of course, for diagnosis of ectopic, and also has a very important role in treatment. We can do salpingectomy in the site of ectopic or salpingotomy. Which is better, salpingectomy or salpingostomy? Salpingectomy. If the other tube is healthy, salpingectomy is better, as the guidelines say. Okay? Why? Because salpingectomy better than salpingotomy, because salpingotomy or salpingostomy is associated with more risk of recurrence. So salpingectomy is the best line of treatment by laparoscopy if the other tube is healthy. Okay? Laparotomy is sometimes used when to take a decision to do laparotomy and not laparoscopy. If the patient hemodynamically unstable, I have no time to do insufflation and do laparoscopy. Okay, so I'm in hurry, so I'll do laparotomy immediately and control the bleeding and do salpingectomy. This happened with hemodynamically unstable patient with severe internal hemorrhage. Of course, correct the blood loss with blood transfusion during the surgery. This is how to do salpingectomy, removal of the tube with the ectopic by laparoscopy. This is salpingotomy, and we do incision, then remove the product of conception. If we left it, if we did hemostasis and left it open like that to heal by secondary intention, this is called salpingostomy. If we close it with suture 7-0 to 1 or 2 layers, okay, Vacryl 7-0 sutures. If we close it after removal of product of conception, it is called salpingotomy. This is the difference between salpingotomy and salpingostomy. Okay? What about if the pregnancy in the cornea or interstitial part? What we are going to do? This is very dangerous because if ruptured, will be horrible bleeding. Okay? So I should diagnose it early. And the corneal pregnancy, some said this is if pregnancy happened in the interstitial part of the tube, the part inside the uterine cornea. Some say it is in the angle of the cornea. Some said it is in any rudimentary horn in bicornate uterus, and so on. Okay? How to diagnose this? Using 2D ultrasound or 3D ultrasound may be more helping in diagnosing corneal pregnancy. Okay? The treatment may be methotrexate injection, systemic or local. I can inject inside the sac itself, local, and generally by giving intramuscular. Okay, I can use either of them or both of them. Surgery by resection of the affected part and to control the bleeding via laparoscopy or laparotomy. Sometimes I may do hysterectomy in patient completed her family and above 40 and no more need for pregnancy. I can remove the uterus by doing hysterectomy. Another type of ectopic pregnancy, cesarean scar ectopic, as you see here, this is the site of the scar and the site of ectopic, diagnosed of course by ultrasound and using also Doppler. There is science to diagnose the cesarean scar ectopic. There must be empty uterine cavity and the empty and the closed cervical canal, placenta or gestation sac embedded in the scar, as in this one, the sac embedded inside the scar, that fill the niche of the scar, as you see here. Absent or thin myometrial layer between the gestation sac and the bladder. This area, the myometrium, the part of myometrium is thin, 2 to 4 millimeter. Intensive vascularization around the scar detected by the Doppler. What is the treatment of cesarean scar pregnancy? Either expected management, and this is rarely done, medical management including systemic methotrexate or local injection of methotrexate or other embryocydes inside the sac. Use another method like uterine artery embolization. You can also do dilatation surgical evacuation by MVA, hysteroscopic resection or vaginal excision, or laparotomy or laparoscopic excision and resuturing to repair the uterus. Okay, I may use ablation using high intensity focused ultrasound ablation, or I may do hysterectomy. Another line of treatment is to do combined treatment or sequential treatment. Like what? Like doing chemotherapy, methotrexate, give the patient methotrexate intramuscular, then after 24 hours do manual vacuum aspiration. okay? Or do uterine artery embolization, then do MVA or D and C, okay? Special type of pregnancy is called heterotopic pregnancy. As in this picture, heterotopic means I have two pregnancy, one intrauterine and one ectopic. Like this one, this is the intrauterine pregnancy, and another one ectopic. It is rare type of pregnancy, constitute one for every 30,000 pregnancies. However, it is increased nowadays because of use of ART, assisted reproductive technology, due to tubal factor and the induction of ovulation. You can see the heterotopic pregnancy, one inside the uterus and another one inside the tube, inside the scar, inside the uh, inside the cervix, in the ovary, inside the abdomen. So whatever is the side in the tube, in the fallopian tube, which is the commonest, okay? So heterotopic pregnancy means normal intrauterine pregnancy and abnormal pregnancy, ectopic pregnancy in different sites, okay? In any different site. I can, of course, manage such a condition by sonographic guided embryo aspiration with or without potassium chloride injection, or methotrexate injection inside the gestational sac, or laparoscopic surgery or laparotomy and the removal of the tube and the ectopic pregnancy, okay? Like self-injectomy, self-injostomy, and so on. Let us go to the third cause of bleeding in early pregnancy, which is molar pregnancy. What is molar pregnancy? This is abnormal pregnancy characterized by varying degree of trophoblastic proliferation, the cytotrophoblast and syncytotrophoblast, with villus hydrops. Okay? There is vesicular swelling of placental villi associated with an absent embryo in case of complete mole, or abnormal embryo in case of partial mole. Okay? Two types of hydative form mole, as I said, complete and partial. The molar pregnancy under the heading of gestation trophoblastic disease. What is the classification of gestation trophoblastic disease to understand the problem? Two big category, hydatiform mole and gestation trophoblastic neoplasia. Okay, hydatiform mole, this is our topic in this lecture, complete mole and partial mole. While gestation trophoblastic neoplasia include post-molar gestation trophoblastic neoplasia, invasive mole, gestational choriocarcinoma, placental site trophoblastic tumor, epithelioid trophoblastic tumor. What is the epidemiology? The overall incidence of molar pregnancy in the United States, 1 in 1,000 pregnancy. Okay? More in North America, Europe, Asian countries, Australia, New Zealand. As I said, Southeast Asia and Japan. What is the epidemiology compared to risk in women aged 21 to 35? Risk of complete mole is 1.9 times higher for women both less than 21 and more than 35. So the younger age and the older age is more exposed to molar pregnancy. Okay. It is also higher in nullipara, people, women with low economic status, history of oral contraceptive use, diet deficient in animal fat, folic acid, and carotene. extreme in risk factors, extreme of maternal age, as I said before. So it is more in women aged more than 35 and in teenager below 20. If there is previous molar pregnancy, this increase the risk 1 to 2% of future pregnancies. Also, other risk factors including spontaneous abortion or infertility, dietary factors, as I said, diet deficient in carotene, smoking. What is the pathophysiology? Complete mole almost always have a chromosomal complement totally derived from paternal gene. Simply look to this picture, please, to understand what is complete mole and what is the partial mole. Okay? Either one sperm fertilized an empty ova without chromosomes. Then this haploid becomes doubled to give me 46XX, for example. Okay? So there is no chromosome inside the ova, only the sperm. And the sperm contain 23, okay, becomes double, reaching 46. Or another way to cause complete mole, two sperms fertilized an empty ova without chromosomes resulted in 46 fertilized ova. Okay, of course, can be XX or XY. While in partial mole, here the condition is different. Either one sperm fertilized an ova containing its chromosomes, and the sperm becomes doubled, so the end result will be 69 chromosome fertilized ova. Or two sperms fertilized an ovum containing its chromosome, so the end result will be 69 chromosomes. So here the number of chromosomes inside the fertilized ova is 69, either 69XXX or 69XXY. There is hydropic villi and the trophoblastic proliferation. There is cytological atypia. Serum beta HCG is high, more than normal pregnancy, of course, and this is usually diagnostic. And of course, it is higher in complete mole than partial mole. As you see in the picture, the uterus is filled with vesicles. Okay? If there is uterine enlargement, there is association with hypertension, preeclampsia, hyperthyroidism with molar pregnancy, and of course also hyperemesis gravidarum. The patient will present with missed period, then vaginal bleeding, sometimes hyperemesis. If thus undiagnosed, maybe preeclampsia and hypertension, hyperthyroidism, and trophoblastic embolization, especially in the lung, causing respiratory problem. The uterus is enlarged, soft, dewy sensation. The adnexia contain bilateral cecal lutein cyst inside the ovary, characteristic for molar pregnancy in about 15% of cases. If you did serum beta HCG, you will find it more than 100,000 milli-international unit per milli. There is no fetal heart sound. In case of partial mole, there is abnormal fetus, there is hydropic degeneration inside the placenta, in the villi. There is vaginal bleeding. The hyperemesis and the hypertension, the hyperthyroidism is less than that with complete mole. Usually beta HCG is less than in complete mole in case of partial mole. Only less than 10% have HCG level more than 100,000. Of course, the most important diagnostic test is quantitative serum beta HCG. Of course, you should do also blood group and RH factor, CBC, coagulation profile, blood work, renal and liver function, urine analysis, thyroid function test because of possibility of hyperthyroidism. By ultrasound, you will see this picture, snowstorm appearance or honeycomb appearance. Also, in the chest, you may find the embolism in the chest, also snowstorm appearance, chest X-ray. You may need also CT scan or PET scan to diagnose metastasis. What is the treatment? Cervical dilatation and suction curettage is the best method under general anesthesia. Dilate the cervix till 12 to 14 millimeter, then complete with suction curettage. Never to give oxytocin except after evacuation of the uterine content because there is risk of embolization. So after evacuation, give oxytocin 20 units per liter drops infusion. Okay. After you complete the evacuation and still bleeding, you can give misoprostol or misergine to control bleeding. In some patients older than 40 and completed their family and not interested to be pregnant later on, you can do hysterectomy to avoid recurrence of such a condition, and this is really needed. If the patient Rh negative, please remember to give Rh immunoglobulin 300 microgram. What about medical complication? Usually spontaneous resolution will happen after evacuation. Okay? Please take care about the pulmonary complication and respiratory distress syndrome, and all facilities should be available like ICU and ventilators and so on. How to do follow-up? By serial quantitative serum beta HCG measurement. First, you will measure it after 48 hours, then every week until 3 consecutive weeks normal level, then monthly until reaching 6 months with negative level. Okay, what is about the guideline for complete molar pregnancy? If HCG reverted to normal within 56 days of the pregnancy event, then follow-up will be for 6 months from the date of uterine evacuation. If HCG has not reverted to normal within 56 days of the pregnancy event, then follow-up will be for 6 months from normalization of the HCG level. Please notice the difference. For partial mole, the follow-up is easier. Once HCG has returned to normal on 2 samples at least 4 weeks apart is quite enough. Ask the patient not to conceive until complete follow-up. COC, combined oral contraception, is one of the best methods so long as there is no contraindication. Is there is rule for prophylactic chemotherapy? there may be some role to prophylactic chemotherapy with brief methotrexate or dactynomycin to prevent post-molar gestational trophoblastic disease. But this is not given except if the patient has high-risk features or the patient has barrier for reliable HCG surveillance. This is to remember the diagnostic criteria for gestational trophoblastic neoplasia. Beta HCG measurement either sustained or increased or after drop becomes elevated, or presence of metastatic disease, especially to the lung and the other body system, or histological diagnosis of gestational trophoblastic neoplasia like invasive mole, gestational choriocarcinoma, placental site trophoblastic disease, and epithelioid trophoblastic disease, as in this picture. Now I finished the bleeding in early pregnancy. Let us go to bleeding late in pregnancy, what's called antepartum hemorrhage, which include placenta previa, portion placentae, vasa previa, and the other local gynecologic causes as cervical carcinoma or cervical polyporectomy and so on. So what about antepartum hemorrhage? This is defined as bleeding from or on the genital tract occurring after 20 weeks gestational age and prior to the birth of the baby. What is the incidence? 3 to 5% of pregnancies. What is the etiology? Obstetric causes, as I said before, placenta previa 1 in 200, placental abruption 1 in 100, vasa previa 1 in 3000, uterine rupture in less than 1% in scarred uterus, or excessive show. This is called obstetric causes of antepartum hemorrhage. Gynecologic causes, cervical ectomy, cervical polyp, neoplasm, vaginal trauma, vaginitis, and so on. General causes like inherited blood disease, unexplained antepartum hemorrhage constitute 40% of antepartum hemorrhage causes. This is the placenta previa, the 4 types of placenta. Please remember lateralis, marginalis, incomplete centralis, and centralis. The lower edge of the placenta here is within 30 millimeters from internal os. Here, the lower edge of the placenta reaching the internal os. Here, the lower edge of the placenta covering the internal os, but not covering the internal os if it is fully dilated. The picture here, the complete centralis, the placenta completely covering the internal os, even if it is fully dilated. So, placenta previa defined as placenta implanted in the lower segment of the uterus, presenting ahead of the leading pool of the fetus. Okay? Placental position is described in relation to the internal os as a millimeter away or millimeter of overlap. So when you do ultrasound, you will say, the placenta, how many millimeter from internal os? Or is it covering the internal os completely or not? And so on. 1 in 200 of pregnancy beyond 24 weeks gestation age. What are the risk factors? Sorry. Either maternal or fetal. Maternal including uterine scarring, previous cesarean section, period DNC, or period perforation of the uterus, period surgical evacuation for abortion, endometritis, increased maternal age, submucous fibroid, multipara, previous history of placenta previa, maternal anemia, and smoking. What are the fetal risk factors? Multiple pregnancy, placenta membranaceae, large placenta as in cases of RH isomerization and diabetes, delayed development of the chorion. What are the clinical features? Painless. This is very important to differentiate it from placental abruption. Painless bright red vaginal bleeding, which is recurrent. So we call it painless, causeless, recurrent vaginal bleeding. Mean Onset of bleeding is 30 weeks gestational age, but onset depends on degree of previa. And please remember that the woman may wake up in a swimming in a pool of blood without any pain. This is very dangerous because there is no pain to alert her. Okay, physical examination. The patient may be anemic from the blood loss or shocked from severe bleeding. The uterus is soft and non-tender. Presenting fetal part is high or displaced because the placenta is implanted in the lower uterine segment. Fetal heart rate usually normal. Please never to do vaginal examination until ruling out placenta previa because it is contraindicated in placenta previa to do PV. Complication. The maternal complication include maternal mortality, rare, hemorrhage, and hypovolemic shock, anemia, acute renal failure, and Sheehan syndrome. Placenta accreta, another placenta accreta spectrum, another complication, especially if there is uterine scar. And hysterectomy, complication of hysterectomy due to the severe bleeding and management of such case that may reach up to stroke. Okay, fetal complications, perinatal mortality, prematurity, intrauterine hypoxia, fetal malpresentation, PRM, risk of fetal blood loss from the placenta, especially if incised during cesarean section. Sometimes the doctor, when they do incision in the uterus during cesarean section, the incision will pass through the placenta and the baby will lose some blood, which is hazardous. The investigation include transvaginal ultrasound is more accurate than abdominal ultrasound, of course, to diagnose the site of the placenta. Okay, what is the management? Our goal to keep the pregnancy intrauterine until the risk of continuing pregnancy outweighs the risk of preterm delivery. Please correct the general condition, do maternal stabilization by giving blood transfusions, intravenous fluid, 2-wide bore cannula, of course, will be inserted before fluid and the blood transfusion. Oxygen for the patient, maternal monitoring for vital signs, urine output, blood loss, blood work, like CBC, hematocrit, INR, partial thromboplastin time, platelet, fibrinogen degradation products, cross-matched blood should be available, electronic fetal monitoring using non-stress test, ultrasound assessment of the fetal and the maternal condition permit determine fetal viability, gestational age, placental position. If the patient Rh negative, please don't forget to give her, especially if the husband is positive and the mother is negative, give the woman RHO GAM, which is Rh immunoglobulin to prevent sensitization. You can do Klauer-Bettig test to determine the extent of fetal-maternal transfusion and to give the adequate dose of Rh immunoglobulin. If the patient less than 37 and has a placenta previa with minimal bleeding, expectant management, admit to the hospital, limit physical activity, no douches, no anemia, no sexual intercourse, give corticosteroid injection, 12 milligram betamethasone, and another dose intramuscular, and another dose after 24-hour intramuscular also, so the total dose is 24 milligram to enhance lung maturity. Delivery when the fetus is mature, reaching 37 weeks, or hemorrhage indicating maternal or fetal compromise. So if there is severe bleeding at any time, this is an emergency situation and should do cesarean section. If the cervix is okay, if there is severe bleeding. But if there is mild bleeding, I will continue until fetal maturity. What if the baby reaching 37 or more, delivered by cesarean section? Another cause for antepartum hemorrhage, which is called appropriate placenta. As you see in the picture here, the problem not the site of the placental implantation because it is implanted high up, no problem with that. This is normal. But the problem in approach placenta is detachment of the placenta, as you see here. And this detachment never happen in normal patient except after delivery of the fetus and separation of the placenta and the delivery of the placenta. But if separation happened early during the pregnancy, can cause revealed bleeding. Bleeding will pass outside the uterus. Or concealed bleeding, the blood will retain inside the uterus. Retroplacental can cause large retroplacental blood clot. Or can be mixed. Part of the blood retained inside and the part of the blood passing outside. So this is called the mixed one. And also placental separation could be total, all the placenta detached or separated, or partial, only part of the placenta like this one is separated. The baby will die if separation include more than 50% of the placenta. 50% or more, the baby will die. Okay, so what is the definition of placental abruption? Partial or total placental detachment that is premature and caused by bleeding as a decidual placental interface. Occurring more than 20 weeks gestational age, account for 1 in 100 of pregnancies beyond 24 weeks of gestation. Risk factors include chronic hypertension is very important, and the preeclampsia, this is the commonest cause. Hypertension with pregnancy is the commonest cause. Okay. Multiparity, previous abruption, short umbilical cord, sudden decompression of an over-descended uterus like in polyhydramnios, preterm premature rupture of membrane, thrombophilia, antiphospholipid syndrome, trauma to the abdomen, tobacco, cocaine, or amphetamine, drugs use, unexplained elevated maternal alpha-fetoprotein level, uterine fibroid, another risk factor. What are the clinical features? First, remember the classification, total versus partial placental detachment. Another types, external, internal, mixed. External is called external or revealed or apparent. Here the blood is sacked downward toward the cervix, and this is less dangerous than the concealed one. The second one is internal, concealed or occult. The blood is sacked upward toward the fetus, may or may not present with vaginal bleeding. Mixed, most of the cases. So most of the cases is mixed between revealed and the concealed, as I explained before. What about the presentation of the patient? You remember placenta previa, we said painless, but here painful. This is a very important difference. Usually painful in 80% of cases. Painful vaginal bleeding. Bleeding not always present if abruption is concealed, but if it is revealed or mixed means revealed plus concealed, there is vaginal bleeding. Uterine tenderness, uterine contractions, and there is hypertonicity in the uterus. Pain of sudden onset, constant, localized to lower back and uterus. There may be shock, anemia according to the blood loss, but remember that shock is out of proportion to the apparent blood loss. Why? Because I have another retained blood inside the uterus of large amount. Also, there may be another cause rather than hypovolemic shock, maybe neurogenic also. Fetal distress, fetal demise, bloody amniotic fluid, coagulopathy. Please look to this table with difference between concealed and revealed. In symptoms, in concealed, there is sudden severe abdominal pain. There is symptoms of preeclampsia sometimes. In revealed, in symptoms, the main complaint is vaginal bleeding, history of the cause, like external trauma, for example. Okay, what about the signs? General examination: in concealed accidental hemorrhage or placental abruption, there is shock and collapse in severe cases, not proportional to the amount of vaginal bleeding. Pulse is rapid and weak, subnormal temperature, and low blood pressure. Signs of preeclampsia may be present. But in revealed placental abruption, the vital signs are proportional to the amount of bleeding. Signs of preeclampsia if present. During abdominal examination, the abdomen in concealed placental abruption is rigid, board-like, tender. Okay? Fetal parts are difficult to be palpated. Fetal heart sound may be absent or there is fetal distress. In local examination, no vaginal bleeding in concealed. Blood is retained inside uterus. Vaginal bleeding is present in mixed type only. While in revealed, the abdomen is lax, uterus is neither hard nor tender, and this is very important to differentiate it between placental abruption with the revealed one and placenta breathing. Fetal parts are easily palpated. Fetal heart sound adhered but may show distress or may be absent. Local examination: vaginal bleeding which is dark or fresh. If cervix is dilated, the placenta is not filled. The complication may be fetal, like perinatal mortality, prematurity, intrauterine hypoxia. Of course, perinatal mortality is high. Maternal complication, including maternal mortality, is a 1%. DIC, very important in placental abruption. Should be careful about that to avoid DIC. Acute renal failure, another important complication. Anemia, hemorrhagic shock, pituitary necrosis, amniotic fluid embolism. What is the investigation? Ultrasound to confirm diagnosis of placental separation. And you may see retroplacental hematoma. Also evaluate the fetal viability, gross presentation, deposition. Lab investigation include blood work, blood count, renal function test, coagulation profile, DIC profile, fibrinogen, prothrombin time, and partial thromboplastin time. Other investigation related to the underlying etiology like preeclampsia, not for urine for proteinuria, and other investigations. Management: correct the general condition of the patient by blood transfusion, fresh blood transfusion, or blood derivatives. Also fluid intravenous, of course through 2 wide bore cannula, oxygen to the woman, maternal monitoring for vital signs, urine output, blood loss, blood work, electronic fetal monitoring using non-stress test or CTG during labor. Okay, the management include, as I said before, blood transfusion and blood products. If the patient Rh negative at the hospital, Rh positive, we should give her Rh immunoglobulin. Okay, if the placental abruption with mild bleeding and the baby is okay and the gestational age is less than 37 weeks, use serial hematocrit to assess concealed bleeding and the delivery when fetus is mature or hemorrhage indicating maternal or fetal compromise. But if gestational age equal to or more than 37 weeks, do correction for general condition and deliver the patient. Okay. In case of abruption with moderate to severe bleeding, give blood transfusion, blood products, correct the general condition, stabilize your patient, correct the coagulation defect. Which method of delivery you will prefer? Vaginal delivery, of course, is better because of risk of bleeding tendency. So vaginal delivery is better if no contraindication. Okay, and no evidence of fetal or maternal distress. But if the cervix is closed and the condition is deteriorating, the baby or the mother, and cervix not opened yet, and or it will take a long journey, we should do emergency cesarean section to save the life of the mother and the fetus. Cesarean section if the fetus and the fetal maternal distress develop with, of course, correction of the general condition and the blood transfusion. The third cause of antepartum hemorrhage is called vasa previa. Please look to these two pictures, vasa previa type 1 and type 2. Here, there is abnormal vessel from umbilical cord passing to the membrane, then to the placenta. This is the abnormal vessel below the presenting part and above the internal os. This is the internal os, and this is the presenting part of the baby, and this is the abnormal vessel. Of course, this vessel is liable for injury. Okay. Another type of vasa previa is the same idea, vessel below the presenting part and above the internal os, but connecting the placenta by subciliary loop on the other side here, and the passing below the presenting part. So, the definition of vasa previa, unprotected fetal vessel pass over the cervical os associated with filamentous insertion of cord into membrane of placenta or subciliary loop, as I let you see in the picture, type 1 or type 2. It happened in 1 in 5,000 delivery and higher in twin pregnancies, and of course in placenta previa cases. Clinical features: painless vaginal bleeding and fetal distress. Remember fetal distress. Tachy to bradyarrhythmia, either tachy or bradycardia. Or sinusoidal pattern with no beat-to-beat variability. If undiagnosed, 50% perinatal mortality, because the bleeding here is coming from the fetus and the baby cannot tolerate even a small amount of blood loss, not like the mother. So the possibility of perinatal mortality is very high, and it increased to 75% if membrane rupture. If diagnosed antenatally on ultrasound without labor or symptom, then 97% survive. Why? Because you diagnosed early before labor. You can protect from injury. You can do cesarean section at the proper time, before labor starts. The diagnosis is typically confirmed by TVS with Doppler. You will see the abnormal vessel passing above the internal os. The investigation which may be done also, the ABT test, the right stain. What is the ABT test? ABT test include sodium hydroxide mixed with blood. Why? To detect if this blood of maternal origin or of fetal origin. How can I differentiate? If it is of fetal origin, the supernatant turns pink. If it is of maternal origin, the supernatant turns yellow. Okay, so the idea from ABT test, which named according to the professor who discovered this test, to differentiate, is it maternal blood or fetal blood? Of course, vasa previa is a bleeding from fetal origin, and the baby can die so fast. Right stain on blood smear and look for nucleated red blood cells. This is also characteristic to the fetal blood, the nucleated red blood cells. What is the management? Plan the cesarean section between 35 to 36 weeks. Why early like that? Because I'm afraid from any rupture of membrane at any time or occurrence of labor pain and the injury of the vessel. Okay, so if I diagnose antenatally, I'll do elective cesarean section at between 35 to 36 gestational age. But what if bleeding happen at any time? Emergency cesarean section, you should do it immediately, okay? Because the baby cannot tolerate the blood loss. This is the last slide. Please remember my 4 books published on Amazon: Textbook of Obstetrics, Textbook of Gynecology, Contraception Handbook, and the multiple choice question. You can see the sample on Amazon. Also, if you are in Egypt, in Mansoura, you can find it in the scientific book library, the medical scientific book library in Mansoura. And this is the link of my YouTube channel, and this is my link on Amazon as an author, and this is another scientific site belong to me. Thank you.